Good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to today's webinar hosted by CareAllies titled How Supporting Risk-Based Agreements Can Advance Value-Based Care. And this is a very exciting topic, and I'm very eager to hear from these gentlemen today. And I'll tell you about them in just a moment. Few items of note before we get started. All attendees have joined today in listen-only mode, so you don't have to worry about muting your microphone. That's been done for you. This webinar is being recorded, so after the presentation, what I'm going to do is I'm going to send everybody an email and I'll give you a link to the recording, and this is also where you can download the slides from today's presentation and contact our speakers and whatnot. So just know that that's coming, and please share that with colleagues and friends. And then during the webinar, we want to hear from you. So please submit your questions. You should all have a little control module that'll have a question section on it that you can ask questions. So if you would ask the questions through there, and you don't have to wait till the Q&A session, you can do that at any time. And we'll get to as many of those as we can during that Q&A session toward the end. And if we don't have time to get to yours, then we'll make sure to follow up via email to answer your question. But please do submit questions. We definitely want to hear from you today. Okay, without further ado, our presenters today are Dr. Joseph Nicholson, or Dr. Joe as we call him, and he's the CMO of CareAllies. And then we have Dr. Timothy Irvine, who's the president of IKP Family Medicine and Renaissance Physicians IPA board member. So thank you, gentlemen, so much for being with us today. And I believe Dr. Joe's gonna kick us off here. So welcome, Dr. Joe.
Awesome. Thank you so much, Garrett. Appreciate the kind introduction. Well, let's hop right in, shall we? So let's go to the next slide and we'll hit our learning objectives for the day. So good afternoon or good morning, right? Depending on your time zone, should start with that. Thanks for joining Dr. Tim Irvine and me today as we examine how physicians can advocate for risk-based contract implementation. We also have a plan to discuss some of the challenges that exist to improve SDOH under some competing models. And then if we're doing our job right, we'll plan to discuss some tactics which can be employed to help providers find the right health plans willing to share the data needed to improve your quality metrics for your own value-based arrangements. Next slide. So in a bit of a 101 moment, right? So forgive me for those of you who are already fluent in ACO speak. I'm going to start a little bit with, what makes your organization an ACO, right? And so for those of you who are really buttoned up and you've already nailed down the corners on your plan to ensure your organization absolutely is an accountable care organization and has the processes and metrics to back it up, it can be a little frustrating, right, to notice that almost any organization can say, right, that they're an ACO and slap that logo on their website, but that's a bit of a spectrum, right? So who in my audience, right, that was in this business 15, 20 years ago, right? Can't really see your hands, but maybe you're raising those. But if you remember medical homes when they first started exploding shortly after the turn of the century, right? ACOs today remind me a little bit of that era, right? We used to use the phrase, if you knew one medical home, you knew one medical home, because, they were so wildly disparate back in the day. Well, ACOs today can have broad-ranging flavors with varying degrees of impact, but we're going to dig in a little more. Now, conversely, when you think of ACO, you think of that traditional Medicare, CMMI, MSSP model, right? Those models are strongly consistent. It's a well-defined, highly regulated model. We all know what that means. But if you're living in that arena and you start talking to your commercial pals, right, about the ACOs they're working with, it gets kind of crazy, right? Because those commercial pals will get you really confused because it's a little bit more of a rodeo on that side. Now, according to Wikipedia, an accountable care organization is a healthcare organization that ties provider reimbursements to quality metrics and reductions in the cost of care, right? Which is fundamentally what we're about. ACOs in the United States, Wikipedia goes on to say, are formed from a group of coordinated healthcare practitioners, and they use alternative payment models. And then they say normally capitation. And I, probably revise the Wikipedia thing to say they certainly use alternative payment models, right, or wound in there. but I would say probably sometimes capitation, right? Now, my pal Tim, he'll talk to you a little bit more later, but they have leaned in. They're doing that fully capitated business and have a really healthy point of view on that. So NPS, right, that capitation, right, is towards the end of that spectrum, right, of a fully mature risk-sharing contract. So if you're in my orbit, you will hear me talk more about from the gospel of diversification, right, diversified portfolio of value-based contracts. And rather than having all your eggs in one basket, we'll talk more about that a little later. But even inside of fee-for-service, right, you'll find value-based contract arrangements that will include a lift in those fee-for-service rates. Those can employ a number of different models and certainly can be part of an ACO portfolio. In general, accountable care organizations do promote higher quality care at lower costs while shifting risk to the providers fundamentally, right? So no surprise, it makes this model, the ACO model, a cornerstone of value-based care. So also maybe well known to this group, but other organizations like NACOS and URAC and NCQA, they've got their own definitions and even their own accreditation programs for ACOs. I would ask you, does your organization have agreement on what it means to be an ACO and how that aligns with your own value-based strategy? So something to ponder. Next slide, please. So let's talk a little bit about ACO Landscape. So according to healthfairs.org, between 2011 and early 2018, the number of ACOs increased more than 17 times, right? And the number of lives covered under those ACOs increased almost 20 times. And the slide on the right gives you a nice breakdown between commercial, Medicare, and Medicaid ACOs during that same time frame. But do remember, right, these can be anything from pay for performance to pay for reporting, right? I'll have a short wrap on that later, all the way to full-on capitation. My frustration is with some of these numbers, I think they have historically often been overstated just in terms of the impact. I think it may be less true today, but in years past, so many organizations were in such a rush to obtain that ACO label, right, to stick on their pamphlets that they created what amounted, in many cases, to that pay for reporting, which I used that phrase earlier, meaning basically if a provider would just report on certain health data, right, to the health plan, they might get a bump in their reimbursement associated with that. And I'd submit in many cases those didn't really move the mark, right, in terms of cost or quality, and probably was more of a contract negotiation tool. But at any rate, my diatribe aside, it's my hope that most of what you see today is indeed a high quality, high impact metric performance arena. So next slide, please. U.S. healthcare payments flowing through advanced models, advanced value-based contracts. So in 2018, 36% of U.S. healthcare payments, representing about 227 million Americans, and 77% of the covered population did flow through a more advanced value-based reimbursement model. You can see commercial payers would say almost a third of their dollars are tied up in some version of a VBC arrangement. Medicare Advantage, slightly more than half of their dollars in a VBC, and then juxtapose that to maybe 39% of all Medicare today is under Medicare Advantage, right? Just a little footnote there. Now note that even traditional Medicare is showing about a 41% of their payments under a value-based arrangement. And that might be a head scratcher, but if you're familiar with MIPS, right, or their alternative payment models, advanced APMs, all payer, other payer options, right, if that language, makes sense to you, that's what that bucket's talking about. And if you're not familiar with all those letters, right, that's a whole nother talk, but it's a thing, right, inside of that fee-for-service arena. Now, before we move off of this, I do want to pitch it to Dr. Tim Irvine to talk a little bit about the opportunity to engage in risk-based arrangements. So, Tim, you're up.
Thanks, Joe.
Thank you.
Can everyone hear me? I hope so. First and foremost, I'd like to say welcome to all the attendees today, myself, and give a big thank you to each and every one of you for allowing both Joe and myself this opportunity to speak. As Joe mentioned, the opportunity to participate in these risk-based agreements is still a viable option. First of all, I'd like to begin by starting off a little background of the organization that I participate in. IKP Family Medicine is based in Houston. A relationship with both Renaissance Physicians Organization, RPO, and CareAllies, the management team, has helped us as an organization advocate for and manage risk-based contracts. As you will learn today, we have accepted both performance and risk-based agreements wholeheartedly within our organization. As a Medicare Advantage population continues to grow, as Joe said, close to 40% now, it becomes imperative that all of our organizations, including your own, to look at that line of business and develop a strategy to incorporate it. Fortunately, as we see here on the slide, as organizations, we have only scratched the surface in regards to engaging our businesses to risk-based agreements. This 2019-2020 data, can we switch the slides, please? That's what I was looking for. Shows only a small percentage of our organizations, less than 20%, have the majority of their revenue at risk. Today, I'd like to present our organization, IKP Family Medicine, as an example of how physician organizations can effectively develop strategies to improve collaboration and increase data sharing as part of their risk-based agreements, all the while supporting improved outcomes for patient populations that may be most impacted by challenges related to their social determinants of health. Lastly, I'd like to acknowledge that for many of your organizations, you guys utilize an employed physician model, different from my own independent practice. Although our ranges may be a bit different, our processes and our end results are the same: high quality care for our patients and profitability for our organizations. As a physician that continues to manage patients on a daily basis, I saw 20 plus patients yesterday. I am comfortable in helping all of you as administrators understand the daily struggles your boots on the ground physicians are dealing with and ways that our organization has improved them. Next slide, please. Now, speaking towards daily struggles, last year, 2020, in the midst of COVID-19, was a financially painful time for all of our organizations. Overnight, we saw a precipitous drop in patient visits and disappearing revenue. Personally, our own organization saw a 45% drop in patient visits, which is now only returning to pre-COVID-19 levels. Additionally, the financial burden of executing virtual visits and the administrative burden of implementing COVID-19 processes was an unexpected expense that occurred at an inopportune time. For some organizations, it became a road too far. For others, such as ourselves, it was both a journey and an opportunity. For our organization, having the dependable cash flow from our contracts, a guaranteed revenue stream, made all the difference. Next slide, please. The question used to be whether or not we wanted to move away from a fee-for-service arrangement with payers and take on value-based arrangements as an organization. COVID-19 taught us a lesson in regards to how finicky fee-for-service can be and how fragile the fee-for-service landscape is. As organizations, many of us have thought about risk as a barrier of figuring out telehealth reimbursement for our capitated contracts. We also were struggling to figure out how we can seamless transition into virtual visits. We were able to do that in our capitated arrangements, and we were even able to visit with patients using telephonic visits without a concern about reimbursement. This allowed our organization to focus on caring for our patients instead of focusing on the financial pressures and operational barriers. As of today, as organizations, we still do not know when the emergency declaration is going to end and if virtual visits will continue to be reimbursed at the current level. This is a mute concern for those who have capitated agreements. Additionally, Many of our personal contracts now offer a care management fee or clinical coordination fee. As our organization has grown, we have come to utilize this PMPM, per member per month remuneration, to help cover the cost of full-time care coordinators. These are truly our essential employees. They are doing much of the heavy lifting to make sure we have the data that is needed to best care of patients and help to address our patients' social determinants of health concerns. Now I will pass it on to Joe to discuss which risk-based contracts may be right for your organization. Next slide.
Thanks, Tim. I love hearing your real world tale, right? Your wrap around how leaning into capitation, right? And that capitated moment really injected a lot of flexibility into your ability to care for patients and just maintain that patient-centric focus, right, during such a difficult time. Thanks for relaying that, and thanks for everything you and your team have done, right, during this pandemic for your patients. We appreciate that. So back to our audience. So which risk-based contracts are right for you in your practice? Stepping into a P4P arrangement can be quick and fairly painless with the right selection criteria, right? So you'll need more sophistication as you move into shared risk, bundle pricing opportunities, and even more sophistication and data tools for managing global capitated arrangements. Organizations that have been willing to pilot risk-based contracts have, in many cases, found implementation does take time and significant effort, right, to get it right. And I'm sure Tim could tell you some of those stories. Those that succeed often start small and slowly transition the percentage of contracts that are risk-based over time. And then others, right, will just jump straight in. And Tim will have to correct me, but I think they might have just went whole hog on that deal right out of the box. But at any rate, the general recommendation, right, is start smaller, get your toe in the water, get comfortable, and then move downstream. Now, note that the new Medicare models have reduced the window for upside risk and accelerated the time frame to engage providers in downside risk. So focusing on key areas that you've already targeted for improvement, right, probably helpful. More often than not, providers may need to revamp key processes within the practice itself to be prepared for that switch. And it does require developing a consistent, repeatable process across payer contracts and does call for some alignment across the practice's clinical and administrative efforts. Next slide, please. So let's think through those considerations for entering those arrangements. So with a volume and variety of quality metrics that physician practices are required to meet when entering into risk arrangements, again, it can be daunting, right, to assess that how beneficial risk-based contract with a payer might be for a practice and its patient population. So with that in mind, let's walk through these a bit and think about the strategy for entering into new arrangements would be kind of the context here, and a few items to weigh and ponder, right? So start with your value-based goals, right? How diversified is your payer portfolio, right? All your eggs in one basket, right? I would say diversify, right? I'd encourage you to strike the right balance between commercial and government contracts that make sense for your practice and your practice focus, right? And does the payer stated goals for quality holistic care match your own? Identify and engage forward-thinking partners. Which payers have progressive policies and technology solutions that simplify your workflow, right? Do they help manage key chronic conditions that may be predominant in your unique practice and portfolio of patients? Do they help close those gaps for your patients with health inequity challenges? And we'll get into that a bit more later. Understanding reporting and data requirements. Does a new payer that you're evaluating have similar and reporting and data requirements to the value-based contracts already in flight, right? If they do not, then that could dramatically impact your workflow if there's a low correlation, high mismatch there. So certainly something to weigh. Does the payer have technology tools available to make it easy for you to evaluate the needs of your patient panel and identify gaps requiring closure? Goal alignment. And contextually, I'm talking mostly here, but does their approach to really just drive throughput and in simplicity for themselves as a payer, right? Or does it really apply tools for evidence-based decision-making to help maximize your value-based contracting results and drive the highest quality for your patients? And last, Probably under the no surprise category, I'd seek out partners that leave you in the driver's seat for decision making rather than just a one size fits all, take it or leave it opportunity. And Tim, before I move off of this slide, I'm going to put you right on the spot. And are there any of these elements that you'd like to highlight and discuss how they impact your practice approach?
Sure. I guess listening to you speak there, Joe, I guess probably one of the biggest things I'd like to mention would be, or reiterate, would be the reporting efficiency, the reporting and data requirements. You're so on point in regards to highlighting, the adverse impact an organization's workflow, to an organization's workflow, if you have a mismatch in regards to data collection. Our organization learned this the hard way early on. We had several contracts, and each was requiring and collecting different reporting data. It became quite cumbersome trying to recall which plan needed what data. And as an organization, we probably weren't as successful back then as we could have been because of it. Now, fast forward to now, our organization now attempts to have similar reporting data across multiple contracts for both consistency and ease. And as you can probably understand, our reporting for the Medicare Advantage plans is much more consistent across the board than our pay-for-performance commercial plans. But that being said, we still try to make it as consistent as we can. Next slide, please. On this side, I'd like to pivot from data collection to data sharing. Let's see here, let me get where I am. There we go. This is truly where the proverbial rubber meets the road, and honestly and probably we could have a full-length discussion just on this one slide. Data sharing is so important in so many ways to the success of an organization. The triad of sharing cycles through the patient, the provider, and the payer, and all three need to be engaged for you as an organization to be effective in managing population health. Patients, they should share information that encompasses their current state of health, blood pressure readings, lab results, I'm thinking A1C, cholesterol numbers, recent procedures and findings, results in diabetic retinal exams and colonoscopies. As providers, we need to focus on the flow of information to and from other providers and physicians. And certainly the payer, they should be willing to provide supporting clinical and cost data about their related patient populations. This will allow organizations such as yourself to assess where improvements are needed and tailor your approach with appropriate outreach and programs. Within our organization, our relationship with CareAllies and Renaissance Physicians organization has had success utilizing an aggregator platform, Arcadia, to bring together multi-source data, thus sharing and collaborating across payers and providers. This has provided us the collection of essential real-time data to improve decision making. As you can all see on this slide, the sharing of pertinent data involves a wide variety of elements, such as healthcare coverage of patients, quality metrics, health outcomes, and utilization data. And in regards to improving population health, understanding how patients' social determinants of health impact their ability to manage their chronic conditions is certainly important. This requires both information and insight, which can be gained through data sharing. Now, moving on, Joe's going to dive a little deeper into the data approach for complex problems. Next slide, please. Thank you.
Yeah, thanks, Tim. That's a great wrap on the importance of data, not to be understated, right? And it's complex. Tim, hammered out different versions of data that can flow into the mix, right? As you're trying to either create algorithms or define processes. Let's talk a little bit about the role of non-traditional data and think about all those data sources you leverage day in, day out. And then, I'd also say, and we all just sort of live where we live, right? Inside of what whatever bubble we're in, but we prototypically rely on our own company's data to inform our decision making, right? It's probably great for the patients or members that are leveraging your services, but typically not so great for data outside your orbit. If you're a physician practice, you're likely relying primarily on EHR data. If you're a payer, you rely primarily on claims data, but you have to live with the resident data lag associated with that, inherent in that process, right? Outside of pharmacy, where if you've got the right switches in place, gives you near real-time data. And then if you'll forgive me, a short wrap on inherently biased algorithms, just to be sure we're thinking through that. Help your data pals also rethink or think through how inherently biased algorithms can work. So as an example, claims data reflects only part of any given patient population that is the part that either has health insurance and access to care, right? So consequently, algorithms using claims data alone to predict population risk are inherently flawed. They can never deliver an accurate risk assessment because they lack visibility into those patients without health insurance or no access to care. Maybe they live in a food desert or a healthcare desert, and it certainly could be a combination thereof. In other words, it gives you a big data hole for patients at the most significant risk for poor health outcomes. So you're more likely to get a holistic picture if you incorporate a number of different data feeds into your own. So questions to ask, right? Is there a local HIE, health information exchange, you can tie into? Have you thought of how to better identify and close gaps for patients who may live in a healthcare desert or food desert, or who may rely entirely on public transportation? Multi-source data becomes particularly important in managing SDOH. Next slide, please. So let's talk a little bit about social determinants of health. As a doctor, right, kind of crazy and humbling to pause and reflect on how little impact the healthcare system has on health outcomes, right? While almost half of the factors are arguably under the patient's control, socioeconomic factors and physical environment make up the other half. And quite a shocking percentage of these patients are in a multi-generational SES environment that's been going on for decades on end. Managing population health requires strategies and tactics to improve patient engagement. I mean, full stop, right? Yet concerns around transportation, living circumstances, and other factors affecting care stand in direct opposition of keeping patients involved in managing their own health. And then keep in mind, many patients may not even make the connection themselves between these barriers and their health. So capturing the right data to address these concerns does mean asking the right questions. Next slide, please. So SDOH can take many forms. Access to food. Is the nearest grocery store a walkable distance? Right, as my buddy from New York used to say, how far is a corner store? Right, I mean, he was visiting me in rural Oklahoma. Right, corner store is a long way away. Housing. Does your patient have stable, safe housing? Is money so tight they're choosing between a gas bill and their medication? Right? Do they have social support when things go wrong? I was shocked in a recent talk I was listening to learn that solo living, right, living alone, becoming the norm for up to 50% of the population in many major cities. The ones cited were big international ones, Oslo, Paris, other places like that. But I did not realize what a big trend that was becoming. Health education is another one. I believe, health education in some ways has been terminally confounded by the internet, right? We've got Twitter, Facebook, social media. Their medical opinions, right, are rampant, often, misleading or misinformation or tied to misinformation can drive me a little bananas. Most of my own family uses Google as their second opinion. Behavioral health in every category, to shift to that, right, has also spiked during this pandemic. Probably no surprise, but again, sad, right? This pandemic has really taken its toll. And then, of course, reliable personal public transportation is critical for healthy food and medical access. So Part of my call to action here is to keep SDOH in your hat band. Consciously think through solutions for your patients that you serve, and it should become a very important part of your overall pop health strategy. Next slide, please. So to continue my call to action on this, right, if you have not deployed your own strategy to address SDOH in your practice or your institution, I encourage you to do so, right? It will act as an accelerant to driving affordability within the total cost of care delivery. So you must first seek to identify and prioritize this most vulnerable population. If you don't have the tools to do this, considering partnering with an organization that can. Once identified, seek to drive change by closing the SDOH gaps for those members. And this will not only improve the health of your members, but again, drive affordability in a powerful way. Empower providers with SDOH tools and awareness. Start a discussion with your own staff if you haven't already. Collaborate with your clients and community partners to address SDOH in your communities. The importance of connectivity with your local nonprofit community-based organizations cannot be emphasized enough, right? CBOs, those community-based organizations, really are the cornerstone for closing those gaps. And then influence policies and regulations within your own institutions, your local government, your national organizations where you have influence. And, you know, I've kind of given a top-down 30,000-foot, talk track there, but Tim, right, you guys are right there in the trenches. So I'm going to put you on the spot again for just sharing, if you will, right, a little bit about what IKP Family Medicine has done in this arena of SDOH.
It's exactly like you said, Joe. It's imperative that all of us as healthcare professionals work as a team to maximize organizational performance. Personally, we've got several third-party vendors we rely on. One comes to mind is Allegis, which helps us with transition of care programs and in-home wellness exams. We also have access to a multitude of chronic care programs that we can refer patients to for chronic disease states, such as congestive heart failure and COPD. And we have payers. We participate regularly in inpatient managers and UMQM meetings with payers to advance the complex needs of our at-risk patients and try to mitigate some of the high utilization trends as soon as we possibly can, and instead of having that stuff carry on and on and on. Next slide, please. Good. Well, so we utilize a three-pronged approach to improving our quality outcomes at IKP Family Medicine. Within the first 90 days, we try to use our physician extenders, our advanced registered nurses, to do a true physical on the patients. The patients, they indeed see this as a true physical. During those times, we touch base with all their metrics that we need to meet, and we discuss it with them. After that physical, we look at what is needed. We ask our chronic care managers to take a look at what gaps of care that we're missing. And what we'll end up doing is we'll call those patients back and try to close out any outstanding gaps. Now, when there are some social determinants and we run across in some difficult situations, we will certainly leverage case management programs like I just mentioned and vendors to help close those gaps and meet those social determinants of health. There have been times that even us, we will send a physician within the practice or a nurse practitioner within the practice to meet the patient at their house to complete some of those gaps and take care of that needed care. But it's not just the physicians that we rely on. This is truly an interdisciplinary team. If you'll notice, it includes physicians, nurse practitioners, registered nurses, social workers, pharmacists, and embedded care coordinators. I mentioned earlier about the embedded care coordinators because these are truly our boots on the ground. Without these guys interacting between patients and between the payer, we would be stuck. So I wish I had a few of those guys on the line to tell them thank you right now. Fortunately, we don't, but those are truly, like I mentioned, the boots on the ground, essential employees that we depend on a day in and day out basis. Next page, please. So what have we seen over the years? Since we started this about 17 years ago, we have seen a nice steady progress. Contrary to what you said, Joe, we did not jump in head first. I can't imagine trying to do that now. Good Lord. That's where it's nice having CareAllies and being a part of the Renaissance Physician Organization has really helped us out significantly. No, we started off doing small amounts of risk-based contracts. At this point, though, yes, we wholeheartedly, like I mentioned earlier, are involved both in capitated risk and risk-based contracts. What else have we seen? This year coming up, we have met 100% of our measures. We are expecting a 5-star rating for the upcoming year. And I wanted to mention, just as an aside, probably what I consider one of the most proudest moments into what our organization has become. We had a physician that joined us a year and a half ago. He was part of a large hospital group, but he kept seeing his metrics falter. They were going down and down and down simply because he didn't have the assistance from his hospital group to help him be successful. So he joined us, like I said, about a year and a half ago, and he's been happily surprised that his metrics, instead of going down, now they're going up. Now, a bit to my chagrin, we just got our recent numbers out, and of all of the physicians within the practice, guess who's number one? The one that joined us a year and a half is now a complete 5-star physician on both Part C and Part D measures across the board. So whether it's for an independent practice like myself or an organization that employs full-time physicians, this is something that is you're able to do and a repeatable process for all the organizations out there. Next page, please. Well, I believe that ends it for my part of the discussion. Joe, is there anything you wanted to mention before we turned it over or back over to Garrett?
I don't think so. I really appreciated your wrap today. It's always, more important for me, honestly, to hear from the practicing doc, right, serving patients in the community, and to hear the real world experience of your efforts, right? I mean, certainly I can bring sort of a national point of view and how our IPA, ACO, CIN partners are performing sort of in the aggregate, but appreciate you being with me in this today.
Thank you.
All right, guys. Well, thank you so much. This has been a great presentation so far. We did have some questions come in, so let's go ahead and dive in no particular order here. First question, and I guess you guys can maybe figure out these aren't directed at either one of you individually. First one is, what amount of time should be expected in transition from fee-for-service to fully capitated?
Well, so Tim and I have already bantered a little bit about this one, right? And I would say, tiptoeing into it, right? And starting smaller before you go big, probably the general recommendation. And then I was, pesky to say maybe Tim had jumped straight in. He's like, no, we didn't, right? So Tim, I'd love to hear from you because you'll have a real world transition to story to tell in terms of how long it took. But I'm thinking, right, top ahead, we're really talking more in terms of years for that full transition to capitation. But to put a short pin in it, I'm going to predict that if you're not in any value-based arrangements at all today, right, you're just fee-for-service, I think in a matter of months, you can, with some effort, launch your first value-based contract. So Tim, react to my wrap there.
I agree with that. It really depends a lot of times the philosophy of the practice or the organization that's looking, is there one physician that wants to do it? Is a whole organization behind it? Because there are some nuts and bolts in regards to your software system and stuff, and just the different process of the way you start thinking about this, almost a reprogramming at times. So starting off with one contract, starting on a pay for performance sort of thing to get your toes cold and wet, and then going head first in it. There's really no hard set rule. It's you kind of take it as a philosophy as a group.
Okay, very good. Next question is kind of a two-part question. It says, how do you approach the distribution of payments for multiple arrangements? And are there things that should be considered when developing a physician comp strategy?
Tim, I started last time. I'll put you on the spot to start, and then I'll follow behind. Or I'm happy to start if you like.
No, so being an independent practice, the way we have our organization situated, it's based on your capitated numbers. So, you get reimbursed based on that. I know I'd mentioned the physician who joined us that was part of the hospital group. That was a bit of a struggle for them because they were based on RVUs, and those RVUs would not take into consideration some of the stuff you're doing on the back side on these capitated agreements. Again, it kind of goes back to your organization's philosophy and how you look and try to decide it. As long as everybody's on the same page, I don't think there's any reimbursement situation that someone's going to just completely say no. Joe, what do you think from an organizational standpoint?
Yeah, no, I'm aligned with everything you said. I think just from sort of that national picture and our experience with IPAs across the nation, I'd say, the organizations that have probably the most challenges specific to those physician comp arrangements are those where you've got a handful of the most senior docs are like the big winners, and then all of the other docs in the organization, may just get a little piece of that. And so from a physician comp structure, particularly if you're starting something new, I would think about something where you don't really have a winners and losers category, right? Certainly you can have a differentiated comp. If you've got guys that are invested enough in time and energy to participate on boards and to be an active physician leader with their groups, right? There should be some differential comp considerations there. But I would encourage you to think through a thoughtful design that rewards people that lean in sort of no matter what level they're at. So that'd be my only additional comment.
Okay. Next question is, what about existing arrangements? When and how do you suggest reevaluating?
Well, we like to try to reevaluate at least on an annual basis. And then there's always changing with the Medicare payments. And then sometimes in regards to CareAllies and Renaissance Physicians, RPO, there's always opportunities. And then you're comparing apples to apples at that point. Is it better to continue a fee for service? You can pull the reports and see how profitable that payer was for you the year prior, and see if it's worthwhile to go to a capitated arrangement with them.
I think that's right. I'd say most folks probably do that exercise at least annually. And then I'd just also flag the pragmatic point of, you ought to be looking at least 6 months in front of the next sort of contract execution, right? So if you have a contract cycle, right, you should be keeping track of those and have those conversations well in front of that contract negotiation or renegotiation or re-up, right? However frisky that dialogue might be, you'll want to be sure you're buttoned up for that conversation.
Great. Next question. We had a couple questions actually come in about this, so I'll just consolidate it into one. Where do you draw the line in assessing and resolving social determinants of health?
Yeah. So for me, and hop in behind me, Tim, but I'd say start where you're at, right? So and it depends in large measure on the resources you have at your fingertips. So I'd say if you're starting from scratch, right, and you have no resources and no dedicated staff and maybe no infrastructure already built around it, I'd start where you are, right? So the American Academy, so I'm a board certified family medicine guy, right? So American Board of Family Medicine, AAFP, actually has a great SDOH tool. It's free. You can download it, print it off, give it to your patients. And that's a way that you can assess your patients as they come in one at a time for SDOH needs. I think the other thing is just start a conversation, right? The more you're talking about SDOH needs and your personal concern as a clinician for your patients that might be on the bubble or in an SDOH gap, the more your staff will begin to be thinking about those. And I think a regular cadence of discussion with your staff specific to SDOH needs, how do we identify them? What community-based organizations can we hold hands with to help close some of those gaps? I would say you begin your own program right there, right? With some pretty simple steps. In a more sophisticated organization, right, I would encourage you to think through leveraging multi-source data in a healthy way that allows you to proactively identify populations at risk, and then literally create a program around that involves nurses and social workers and pharmacists in a stronger combination with a multi-pronged CBO effort. So that'd be my quick opening commentary. Tim, anything you'd like to add?
You mentioned multi-source data. I have really, over the years, we've been participating in a UMQM meeting on a monthly basis for our Cigna MA plan for as long as I can recall. I am still amazed after all these years how much information you can get for someone's needs, some social determinant needs, just by going to that meeting. These folks that you see, they're readmitted. They're requesting this on a monthly or every other monthly basis. You can use that as this is a quick fix, or not necessarily a quick fix, but this is someone we need to focus on. Now, if you want to be overwhelmed, when you're in the room with me, you simply ask the patient, what do you need to be successful in your healthcare? And you will quickly be overwhelmed with what they list. I need a bedside commode. I need a ramp to get my power scooter into the house. I need a door built so I can get my power scooter around the house. You would get overwhelmed that way. But finding something in between, doing like I do, something that I've seen a couple times in the office and I'm concerned about them, and then going to those UMQM meetings has really paid benefits for our organization.
That's great. That's great. So we got time for one more question, and this one is kind of a fun one, and I'm just curious how you guys will respond. Is the future of ACO success based on a socialistic philosophy or a capitalistic philosophy?
Oh, of course you do that to us, Garrett. That's great. I almost need to think about that for a minute. Tim, do you have a top of head reaction to it, or I'll hop in?
Well, for the general population, for healthcare as a whole, I would say it almost would be beneficial if it was socialistic. But from a person who's trying to put three teenagers through school and stuff, I hope it it continues the way it is.
Well, so I guess my just top line reaction, right? It's an interesting question, right? Because in the interesting moment, right, it sort of hits on both cylinders, right? Because the ACO output, right? It's a make no mistake, it is a population health play, right? Which I would say feels like the flavor in some ways of socialism in terms of, because you're addressing the population, but it rings the buzzer financially for the capitalist because most docs I know that are heavily invested in risk-based contracts and are doing the right things for their patient, they, like Tim, right? They've got 5 stars. They are hitting all of the quality metrics. Guess what? They're also hitting the financial cover off the ball because of their performance, and they have lowered the total cost of care delivery. And so I'm going to give a cheater answer and say both. That'll be the Joe answer.
Well, great. Well, thank you both so much. Unfortunately, we're out of time. And so if you have a question that we weren't able to get to, we'll make sure to get to you via email afterwards and continue to submit them if you do have something last minute here that you want to ask. But at this time, we're going to need to conclude. Thank you both again so much for the presentation. It was very informative. As we conclude here, I would like to encourage you all to visit the ACOexhibithall.com CareAllies booth. They have an interactive exhibit booth there at again, ACOexhibithall.com, and you can read more about them, interact with the team, learn a little bit more. So it's pretty cool. So I encourage you to check it out. And then lastly, if you have any specific questions for either of our panelists or the CareAllies team, here's their contact information here. Feel free to contact them directly or reach out to me, and I'll be happy to put you in touch with who you need to be in touch with. And in the interim, thank you all so much for attending. And again, I'll be sending out a link to the recording after the presentation, so probably this evening at the very latest tomorrow. And it'll also be a place where you can download the slides from today's presentation. So we hope that you share that and have a chance to review it again on your own. So thank you again so much for attending. We really appreciate it. Stay safe, be healthy, and have a great rest of your day. Thank you.
Thanks, Garrett.
Thank you, Garrett.
Thanks, Tim.
Bye-bye.